I want to thank you for the invitation to come to this great meeting. It was really an honor to be invited, and I've really enjoyed being here so far, meeting everybody and getting to know the people here in Korea and Asia. So thank you very much for the invitation. I just want to start by saying that. So my talk is about converting the appropriate child who already has Fontan palliation into a biventricular circulation. Some of the considerations I've outlined here, and most of these are kind of just thoughts that people, I think, in general have. For a while, biventricular conversion seemed to be a very popular topic, when taken at face value. The general idea or the general thought is two ventricles? Are two ventricles better than one? And I think in some instances you may see some people take the thought that if it's possible, maybe we should do it. So I always ask, how far do you think we should really go to achieve a biventricular circulation? Is that really better? Should the timing or stage of single ventricle palliation play a role in determining when or if we should pursue a biventricular circulation? Oftentimes, if we're trying to decide we're doing it after the Glen, we're not usually going to a Fontan and then coming back. So I don't think that answer has been determined yet. And I think the more difficult question is honestly, how do we adequately counsel families when somebody, say, has already a Fontan circulation and we're now going to counsel them to say, we should do something different, and how do we adequately educate them for them to really understand what that means? There's always been this notion that a good Fontan is better than a bad two-ventricle circulation, and we are still trying to determine the truth of that. So if we look at Fontan physiology, as we've talked about previously in this meeting, current state, close to about 1,000 Fontans are performed per year in the United States. With improved techniques, this has led to improved outcomes, and currently a 30-year outcome of Fontan has been estimated about 85% survival. In the immediate to long-term period, we do know that chronically elevated CVP and impaired cardiac output lead to essentially heart failure, development of heart failure, decrease in exercise capacity, overall survival declines, and complications increase. 1/3 of these Fontan patients will require surgical reintervention at some point in their life, and 2/3 will require percutaneous reinterventions. And currently, less than 40% of Fontan patients would rate their health quality as excellent. So there's room to improve there. Some of the examples of the Fontan morbidity include ventricular dysfunction, altered bone density, decreased muscle mass, renal dysfunction, lymphatic insufficiency, pulmonary AVMs, plastic bronchitis, liver fibrosis, Fontan-associated liver disease, as we know. So is this true that there is no such thing as a good Fontan, and that all Fontans eventually require transplantation? Well, if we look at the incidence of transplant, the incidence of heart transplantation in Fontan is not as high as we might think. In a population-based study in Australia, currently the rate of transplantation for this population was only 3%. And a study with the Pediatric Heart Network showed that heart transplant within 15 years of Fontan can vary between 0 to 20%. So certainly not 100% of these Fontans are coming to transplant. The reason for this, however, might be a little different than what we think. Outcomes of heart transplant in Fontan patients is not great, a 1-year survival of about 80% and a 5-year survival about 76%. And I think this is probably reflected a little bit in the fact that we're still determining when these patients should be put forward for transplant. It's not a straightforward decision. And oftentimes, when they do end up coming to transplant, they're already in a very debilitated state, which makes them even worse transplant candidates. There's a high wait list priority, which is dependent on end-stage disease, and oftentimes these patients, when they're listed, can be waiting for a long time. And then there's a possibility of them needing a potentially heart-liver transplant. This paper just basically showed the idea that, is it possible that if you have two good ventricles that are pumping in a Fontan circulation, does that make you somehow better? Is a left ventricle better than a right ventricle? And this has shown that there's really no difference. And so the issues with Fontan doesn't have to do necessarily with the heart. So with these with this knowledge about Fontans, that basically begged the question of should we start investigating other options, and is a complex biventricular repair better than a Fontan? Well, that's also difficult to know, and this is a paper from Ramamani and their experience in Boston. They have a lot of experience with biventricular conversion, but this was specifically looking at patients who have already undergone a Fontan, and so a failing Fontan, and attempts that they've done to go with a biventricular repair. There was only 23 patients. It's a very short follow-up. They treated 6 of them with a staged approach, but the mortality rate was 22%, so it was pretty high. And in the patients who survived, their freedom from reoperation or reintervention was only 20% at 5 years. The conversions required multiple things, including valve replacement, placement of an RVDPA conduit, and a pacemaker in 17%. So you could argue, are these patients really better off with this type of physiology than their Fontan? 36% of these patients had an RV pressure greater than 2/3 systemic, and their median left ventricular end diastolic pressure was as high as 15. Interestingly, they found that the patients who did best in this cohort were the patients who were not failing Fontans. These were patients who were actually tolerating their Fontans better, which is not surprising. So there's really no definite criteria for consideration for biventricular conversion in these patients. Primary biventricular repair was undertaken if they had a left ventricle end diastolic volume of greater than 30. They found that elevated left ventricular end diastolic pressures of greater than 13 was a predictor of unsuccessful biventricular repair. And in many cases, many of these failing Fontans will have a LV-EDP of 13 or greater. Patients with developing morbidities have worse late survival, and those are theoretically the patients who would benefit most from some type of alternative therapy, because we've determined that those are failing Fontans. It's really unknown whether the Fontan patients who are doing well will develop these adverse issues. And so if those are the patients who did the best in these Fontan takedown biventricular conversions, it's difficult to really recommend that procedure for them when we don't really know if they would have developed further adverse issues and maybe became worse patients. So it makes elective takedown difficult to recommend. And the final caveat is, Ed Hickey published this very good series about looking at patients who really were pushed towards biventricular repair. And inappropriate pursuit of biventricular repair in these borderline patients really led to increased mortality. So the question then is, so you have a patient who is, quote, a failing Fontan, and should these patients pursue a biventricular repair? And I would say that these have to be very specific patients who would benefit, in my mind, from this type of strategy. And we had one patient that we did a few years ago who I think met these criteria. This was a 12-year-old male with double outlet right ventricle, VSD, and interrupted aortic arch that was treated initially at a different facility. He underwent in Norwood with a BTT shunt that was followed by a Glenn and then an extracardiac lateral tunnel Fontan at the age of about 3 years old. He started developing liver-associated issues. He developed hepatomegaly and some mild liver fibrosis on biopsy, but his echoes showed an unobstructed Fontan circuit. His AV valves were good. He had good ventricular function, and his caths showed, relatively expected, slightly high 14 millimeter venous pressure in the Fontan. The wedge was only 7, and the PVR was 1.5. So at his original hospital, he underwent a multidisciplinary conference discussion, and they felt that the VSD in the aorta was too anterior for a biventricular conversion. So they sort of stayed the course. And eventually the family relocated and ended up in Atlanta. So he was put forth in so this is his MRI, and as you can see that, his outflow tract, his left ventricular outflow tract is a little bit small here, but in general, he's got good sized ventricles. And so he did have potential options. We discussed him at our conference, and because of the urgency with the liver fibrosis that was present, we felt that, if he was candidate for a different type of procedure, we should consider that. He had low EDP, had good sized ventricles. And we felt he was a candidate for a biventricular conversion by taking down his DKS and doing an arterial switch and closing his VSD and then taking his Fontan down. This is a short video just showing, the procedure. So the patient's head is to the left, the head, the feet is to the right. And so what we're looking at here, that was his Fontan. He had a pericardial roll type of Fontan, which is kind of something that was done at this other institution. We've cross-clamped the heart, and here we're opening up the atrium. I had never seen this type of Fontan before, so we were trying to figure out what's the best way to reconnect the IVC to this atrium, and so ended up opening up the atrium here, and then here we were opening up the actual Fontan, and then I just connected the two, and that would be the pathway from the IVC into the heart. Now, if you remember his left ventricular outflow tract, which was going to be, after the arterial switch, would be his right ventricular outflow tract, was small. And so I felt that, leaving his Glen intact might be the best solution because, I'm of the opinion that if we're actually altering physiology, if we're adding an RVPA conduit, then I think that is a morbidity that is added to the patient because we know we'll have to have multiple RVPA conduit changes. So here I'm taking down the Fontan as it enters into the inferior aspect of the right pulmonary artery. Here's the RPA. You can see the line coming out through it, and here just closing off the cardiac side of that Fontan. And here now dividing the DKS. So this is the aorta on top, and you can see it's probably about a quarter the size of the pulmonary artery. So just taking my time to divide this without injuring any structures because we're still trying to figure out the anatomy a little bit here. And so here the aorta is getting taken off. And this, here's the aortic valve. You can see, you get a sense of the size of this aortic valve compared to the pulmonary side, which is this entire thing. Just identifying the coronaries and the pathway. And then here I'm going to divide the pulmonary artery, and you can see how big that is compared to the aorta. So after the pulmonary artery is divided, and again you can see the size mismatch, again sort of prompting the decision to leave the Glen intact because I did not want to come across the pulmonary valve and now give him something new where he would need pulmonary valve reconstructions or pulmonary valve replacements over his lifetime. The idea here was to give him one operation that he potentially would not need another operation again. So here's the VSD on this side here. The left ventricular outflow tract is over here. This is the pulmonary, the pulmonary valve, pulmonary trunk. So the VSD is closed, and now the left ventricular outflow tract is going to the pulmonary valve. And here the coronary arteries will be taken off. When I do coronary transfers and arterial switches, I always do this where I leave this sort of rectangular shape. So that gives my orientation, knowing that, if that's the orientation where the aorta was going out, I always keep that orientation when it gets transferred to the pulmonary artery so that there's no twisting or kinking or anything like that. So here's the coronary transfer being completed. We did a Lecomte maneuver, bringing the branch pulmonaris anterior. And then here the aorta is being reconnected to the ascending aorta. And this is the pulmonary trunk. Here you can see this is the branch pulmonary arteries. So repairing the sinuses. We didn't have any pericardium, so this is just a bovine pericardium to repair the sinuses where the coronaries were once. The clamp was taken off, and now the newly constructed pulmonary trunk is now going to be anastomosed to the branch pulmonary arteries here. And that's pretty much the operation. And so I don't know how to advance, maybe enter. So the patient did remarkably well. He went home in 6 days. He was extubated on the first day. was off drips by post-op day 4 and was transferred to our floor. Continues to do well with some improvement in his liver function. So this was sort of that rare patient that, or I guess you could say the ideal patient that would constitute, in my opinion, taking down a Fontan, making a biventricular repair. He didn't require an RVDP conduit. There's no valve replacement. He didn't develop heart block by trying to enlarge a VSD. And in addition, we didn't make him a worse candidate for transplantation. As we've talked about, oftentimes when you push these biventricular repairs, you end up with higher left ventricular end-diastolic pressures, which translates into pulmonary vascular disease, which can hurt your chances for actual cardiac transplant. So in these patients, it's difficult to assess the burden of reinterventions, and I would ask the question, how do we actually define success when we convert these patients to biventricular physiology? So in conclusion, I would stress that exploration of alternative solutions remains a necessary endeavor in these Fontan patients, but proper selection is really essential when we're trying to decide on a biventricular strategy. Adequate counseling of the families is difficult, if not impossible. I mean, think about trying to educate a family with no medical background about what we're talking about, taking them from a potentially stable physiology to something that might be worse. And sometimes transplantation may be the best form of biventricular conversion. Thank you very much for your attention.